Hello, everybody. Welcome back to Psychedelics Today. This is your host, Kyle Bullard. Today on the show, we are joined by Dr. Jennifer Montjoy. This episode was recorded live at the ICPR conference in Haarlem over in the Netherlands. ICPR, the Interdisciplinary Conference on Psychedelic Research, is Europe's leading academic conference dedicating to advancing psychedelic research and therapies, and is organized by the Open Foundation since 2010. If you want to learn more about ICPR, you can check that out on the web at icpr-conference.com. Really awesome conference. I had so much fun over there. And it was really great to meet everybody, especially for everybody in Europe, all of our friends and colleagues in Europe that we don't typically get to always see in the events in the States. So I think that was probably the best part for me, is just really getting to connect with a lot of our European friends and colleagues. And then thank you for everybody who showed up and said hi to us at the table that we had there. Really fun, really, really fun. I was planning on recording a little bit more, but yeah, I got distracted by hanging out at the conference table and just chatting with people. But I came across Dr. Montjoy's research because another student actually of ours, Saskia Villa, she was actually a presenter with Dr. Montjoy for a poster in one of the halls. So Saskia introduced me to Jennifer, and they both shared the research that they were presenting there at ICPR, which was on ketamine and PTSD. And of course, if you've been following us here at Psychedelics Today, that grabbed my attention because of the ketamine and trauma treatment series that Veronica Gold from Polaris and I put together a few months ago. If you want to check that out, you can check that out at our psychedeliceducationcenter.com, and that's the ketamine and trauma treatment series. It might go really well with this interview. I'm going to leave this intro at that. We'll dive in to this episode. But before we do, just some reminders. If you like what we're doing here at Psychedelics Today, feel free to leave a review on iTunes, wherever you listen to podcasts, and subscribe to our podcast wherever you listen. And then we also have some upcoming cohorts for our Navigating Psychedelics class. You can learn more at psychedeliceducationcenter.com and go on over to Navigating Psychedelics for clinicians and therapists. There's going to be 4 classes kicking off, and that starts in November. So it's we're going to have a Tuesday and Wednesday class, and they're going to be more geared towards the mountain time. So we have 6 p.m. mountain time and 8 p.m. mountain time. So that's 8 Eastern and 10 Eastern. So if you're mountain time or on the West Coast, check that out. Or if you like to stay up late, if you're on the East Coast, you can check that out. Those dates run from November 29th through January 24th. And again, you can check more out at psychedeliceducationcenter.com. I'm going to jump into the interview. I hope everybody is having a wonderful week whenever you're listening to this. I'm actually recording this post-Horizon, so my throat is a little raw from all the speaking to everybody. So we'll catch you on the other side and enjoy this episode with Dr. Jennifer Montjoy. Hello, everybody. Welcome back to Psychedelics Today. Really excited to have Jen Montjoy here from TRIPP. Welcome to the show. We're actually live here in person at the ICPR conference in Haarlem and in the Netherlands. So yeah, really excited for this.
Thank you. Thank you, Kyle. Yeah. It's been a great conference.
Yeah. Anything that really has stood out for you so far?
Well, I think because it's an international conference, one thing that stood out is the location.
Yeah.
And being in Haarlem, which they call the Little Amsterdam, has been really, really sweet. So a lot of familiar faces from the States, but also new faces from all over Europe.
Yeah. It's fun seeing worlds kind of merge together, which is really nice.
It is. I think for the first time, really post-COVID or since before the pandemic.
Yeah, I know it's like that post-COVID anxiety of being in large groups. I'm sure some people are feeling that, but it feels good to be back in person.
Yeah, it really does. Yeah, it really does. I think most of us are longing for reconnection
Yeah. Yeah. And I know,
Yeah.
I think, well, I know for myself, like sometimes when you're doing this work alone in the world, or just like, we're all remote and we don't always get to see like each other all the time, it, brings back a little bit of that spark. It's like, oh, yes, this is why we're doing the work. I
Yes.
think in the past few years, you get your ups and downs where you're like, what am I doing? But yeah, when we come together in community, it like reignites that. And we're like, yes, this is why I do this work.
100%.
Yeah.
100%. So, yeah, making new connections, networking and meeting like-minded, like-hearted people.
Yeah.
Yeah, it's pretty sweet.
Yeah. So could you do a little bit of introduction of who you are and some of your work that you do?
Sure. Yeah, thanks again for having me. So my name is Jen Montjoy. I'm based in Tucson, Arizona, and I am a PhD prepared psychiatric nurse practitioner. I have a private practice in Tucson and Mesa called Resilience Behavioral Health Solutions, and we specialize in psychedelic-assisted psychotherapy utilizing ketamine. But I'm here at ICPR promoting our 501c3. So we have a public service nonprofit called TRIPP. It's the Transpersonal Research Institute of Psychotherapeutic Psychedelics. And so through TRIPP, we teach licensed clinicians in small, intimate trainings that are experiential, 4-day experiential trainings in Tucson. So we're here promoting those. And then also offering retreats, primarily for clinicians, so mental health clinicians, first-line clinicians as well, to have respite. And those are also small and intimate in Tucson.
Awesome. And then what caught my attention was that you're presenting a poster here with actually one of our Vital students. And it caught my attention because it was about ketamine and post-traumatic stress. And we did a ketamine and trauma treatment series, I guess a year ago, and launched it a couple months ago. And, this has just been a fascinating conversation over the years of having it. Because I know there's been like a lot of kind of different debates about using ketamine for the treatment of PTSD. Mm-hmm. So I would love to dive into a little bit of your research there and some of your work.
You bet. Yeah. So it was interesting. What I found, so I've facilitated now more than 300 KAP sessions over the last few years. And my practice has been primarily referrals from other clinicians in the community. What was striking were the ACE, or Adverse Childhood Experience scores. Approximately 2/3 have had ACE scores of 4 or higher.
Oh, wow. And what is that out of for people that don't know?
So, so it's a yes or no questionnaire, and hits on some pretty solid domains of, childhood neglect, abuse, adversities, for a total of 10 being the highest. So 4 and higher are relevant because these folks tend to struggle more with mental health comorbidities, with also medical comorbidities and early mortality. So that's why that number is important.
Yeah.
And most of whom also met criteria for DSM-5 criteria for chronic PTSD. And so I have found racemic ketamine to be extremely helpful for folks with PTSD. And we were here sharing clinical outcome data. We collected up until March of this year, 2022. Okay. So it was a retrospective data analysis. And what we found is that with this approach, and it's a gradual titration, I think that's one thing that is maybe different about the approach that I use with intramuscular ketamine in my practice, is that we start low and we really individualize and fine-tune the dosages based on people's physiological response, but also their subjective, response and how well they're tolerating, and gradually titrating up over the course of about 6 sessions, usually. Again, 2/3 of folks receive 6 induction KAP sessions, intramuscular KAP.
And how were they spaced out?
So 6 sessions within 3 weeks.
Okay.
And then about 1/3 received 3 induction sessions over the course of about 10 days.
Okay.
Within 10 days.
Okay. Cool.
Yeah.
And then what did you notice after those those sessions, those 6 sessions?
Yeah, it's been fascinating to kind of witness. Many of these folks are very motivated. They're being referred to me to resilience because they've exhausted all available traditional interventions, usually pharmaceutical and psychotherapeutic. So they're motivated. They have a lot of tools, a lot of therapeutic tools in their toolbox. They're just stuck.
Yeah.
So really what I've noticed is a gradual shift from kind of an external locus of control perspective to usually around the third or fourth induction session to kind of this shift of more internal locus of control and agency, self-efficacy.
Yeah. Which I think is important for trauma, right? Because I think, at least in my experience with clients, there is like this sense of agency taken away and lack of trust in the body, lack of trust of, say, the universe and the environment.
Yeah.
And to like regain a little bit of that agency is, I think, part of the work there.
It's critical.
Yeah.
It's critical. And I would say even like mistrusting self.
Yeah, exactly.
Right?
Yeah.
And we see like indecisiveness and fear and angst.
Yeah.
Yeah. It's really, it's beautiful. So, with the clinical outcome data, we found that 86% were responders. So, and what that means.
That's pretty significant.
It was significant and statistically significant as well. So a score of an improvement in at least 10 points with a PCL5.
Wow.
And then reassessment as well.
Yeah. And are you doing any sort of like follow up with them, like a couple weeks or months to see if they're keeping that score high?
With the way resilience is set up, we aren't collecting longitudinal data, primarily because folks are referred to us by their psychotherapists.
Oh, okay.
So they're plugged in typically in the community. We do offer integration for folks who aren't plugged in with a therapist. And I just defended the data in my dissertation in June. So, but we need randomized controlled data, which this wasn't, right? This is just simply reporting clinical outcomes. It was an IRB approved project and through the University of Arizona. But we do. I think the implications are, that we need more research that's set up, right? More of a randomized control trial design with longitudinal follow-up, like you're asking about.
Did you happen to go to Dr. Christine Hauskeller's talk this morning, kind of debating randomized trials?
Like placebo-controlled or in general?
No, just, kind of saying we don't need this. We need other types of research and saying how some of the randomized controlled trials, especially in psychedelic medicine, might be kind of actually tough to validate because, there's so much to it. It's really interesting. I think it stirred up a lot of conversation for sure. But, being able to collect like real world evidence like this, I think is really important, right? Because there's not much out there. And I remember when I was putting this program together, there's not much research out there. And so when I saw your poster, I was like, oh man, here's something that we can look to.
Right.
What made you focus on PTSD and ketamine?
Right. So I think part of it for me, it wasn't like planned or premeditated. It just, I think what's happening is a lot of folks are being labeled treatment resistant and are being sent to me because, like I said, that what's available hasn't worked for them.
Yeah.
And in terms of their suffering and symptom remission, and it makes sense, right? Because our model is very, very much about managing symptoms and coping, that's important for suffering to alleviate, but it doesn't necessarily heal the foundational wounds, right? It's not really a healing model of healthcare, right? Mental health care in particular. So we notice patterns in our clients, right? Our caseloads and our patients, and that's why collecting those psychometrics are helpful because we can see these trends.
Yeah. So
it really was a kind of a post hoc, right, discovery on in doing some analyses.
Yeah.
Yeah.
And where do you see the potential for ketamine for PTSD? Because I know years ago, there was some argument saying, like, especially with those that have pretty significant dissociative symptoms with PTSD, adding a dissociative anesthetic to the mix may actually not be beneficial. I was doing some thinking about that and some of my own experiences. And I brought this up in another conversation of like having a near-death experience. I do kind of like do that dissociation. When I feel that dissociation, it kind of almost reminds me of that dying process. And then I'm like, whoa, there's like, this big process that comes up. But it's also, that's where the work is for me. It's like, how do I find comfort in that? How do I ground that in my body? But yeah, like where do you see the benefit for ketamine with PTSD? Because I know I think the titration is really important when it comes to trauma, but
yeah. I think with this approach, that's one of the keys is especially, utilizing an attachment theory approach, which includes, Richard Schwartz's, internal family systems, which often unfolds organically, right? These parts arise like in psychedelic experiences, including ketamine. So I think that some of the debate is unwarranted because I think, to dissociate that, I think that word is kind of nebulous. I do. I think that it, in terms of semantics, so we know that it's part of how it's a survival mechanism, right? A defense mechanism. What's interesting about what I'm seeing in terms of folks, many of these folks have tremendous trauma, childhood trauma. And to dissociate is actually helpful in the experience for a couple of reasons. One, because it's not activating the sympathetic nervous system. So ketamine is an anxiolytic, meaning, right, it decreases anxiety. The other thing is what we have found through functional MRI research and EEG is that it affects the communication between our working memory and our emotional memory. So our cortical memory and our limbic region memory, right? And the limbic region is what then activates our autonomic nervous system, right? Yeah. Fight, flight, freeze. And so that is attenuated with this medicine. And it's a fantastic tool because often if something does arise, a memory that's specific to a traumatic experience or experiences in the session, the sympathetic nervous system is not triggered.
Yeah.
And so I think being able to experience that as more of a witness, an observer, really helps alleviate the angst in our day-to-day normal mind.
Yeah.
And so it's not activating. So I would say that it's actually a helpful tool in that way.
I've heard like some people just say it's like really resourcing. And on the dissociation thing, Veronica Gold years ago when I had her on the podcast, I think she threw this out there saying, somebody mentioned it was like, I got to dissociate from my dissociation. And it's like bringing awareness that I was even dissociated to begin with, being able to kind of step outside of that dissociative state. But yeah, I mean, in some of my work, I've noticed people saying it feels resourcing, right? It's like I get to just like relax. And thinking about when people are in that sympathetic drive, that's really hard to do, especially when it's trauma based, right? Like to relax and to feel resourced, that's like really triggering for a lot of people that have grown up maybe in environments where they're constantly on edge, or you're in dangerous environments where you need to be for survival. So to actually finally feel a little bit of that resourcing, it's like that's the medicine, I think.
Agreed. I think it's super helpful. I really do. I think in terms of pharmacologically, that racemic ketamine it's a dynamic medicine. Some clinicians are using it at psycholytic doses to do psychoanalysis. Gita Vade is an example of someone doing that.
I love her work.
Yeah, she's great. So I think, again, and now we have a little bit of data, again, clinical outcome data supporting its effectiveness, not longitudinal, but in terms of the induction, during that induction phase, about a week out, folks are doing and feeling much better and much calmer.
Which is important. Yeah. So you brought up psycholytic therapy. I'm wondering, what's your model? Can you talk a little bit about that titration approach? And, what does that look like?
Yeah. And I share this in my 4-day trainings as well. The dosage, we focus on intramuscular and troches, so oral dosing and the bioavailability of the different routes of administration. But generally, the titration, if folks are tolerating it well, we titrate up 5 to 10 milligrams at each session, approximately. Yeah. Sometimes we'll go a little bit faster, but it's administered. I also use a 2-dose approach. So they receive the medicine. So for example, if they're receiving a total of 40 milligrams intramuscularly, I'll administer 20 and 20 or 15 and 25. And so typically...
And how far is that spaced out? They get one injection and then...
10 minutes later. Yeah. And that's really based... My approach has been very, very client, very person-centered. It's been based on feedback and, like I said, hundreds of sessions with folks.
Yeah.
So, yeah, and it's worked, I think, really well for the population I work with.
Yeah.
Yeah.
Oh, that's awesome.
Yeah.
Are you doing any sort of psychedelic therapy? Are you really I guess it depends on the dose, right?
Mm-hmm.
Of how far somebody's going in. But what does that session look like?
So again, because my approach is very, very person-centric, very patient-led, there are times that, parts arise organically. Mm. What's fascinating is there are other times that folks will walk themselves through, whether they're verbalizing it during or right after the psychoactive phase, sharing with me what happened. And again, Richard Schwartz talks about this, how, it just unfolds organically, even if they maybe they may not realize that it's internal family systems, but they're essentially, unburdening, they're, managing these defenses, these parts, and going in and nurturing their exile, I call them original wounds, those young parts, those tender, selves. So I do think it's helpful to have a skill set and general understanding of that, so that you know what's happening in real time.
Yeah.
But for the most part, I think I subscribe to the philosophy that we all have an inner healer. We all have the inner wisdom, but most of us don't have access to it because we have these managing protectors from our trauma. Yeah.
And sometimes hard to tap into.
Yeah.
Really. Do you use that language at all with clients, talking about the inner healer, this inner healing intelligence? And do you notice any pushback, or are people what is that? How do I trust that?
Yeah, that's a great question. And I think we want to be sensitive to that. So in my intakes with new clients, I ask about, if they have any spiritual practices, with no agenda, on my end, just so that I do use verbiage that resonates or conversely doesn't turn them off.
Yeah.
But I also open and close every session. And I think that's critical. Intention for each session set and discussed is also really critical for outcomes and for context of these experiences, which can be kind of strange.
Yeah.
Right?
Yeah.
Yeah.
I'm glad you say that.
Yes.
Bring the strangeness back to psychedelics and just exceptional experience. Sometimes they get strange, and I like when people can admit that.
Yeah, we want to normalize that, for folks, that it's seemingly random, and often there are pearls, but the context of those pearls are within or around the intention.
Yeah.
And so for integration and, again, processing and unpacking after, the intention is critical. And I think opening and closing and using the language that resonates for them. So to your question, I'll often in the opening, I'll, ask the higher self to step into the light, to take the reins, and that let all those parts know that the goal here is not to annihilate or bypass them. That's the language I consistently use in opening, because as the facilitator, we want to ally with those parts too. We're not the enemy. And
So any people coming in that may be psychedelically literate, are they coming in wanting an ego death experience? And maybe tie into a question that I wanted to ask about titration. What is titration for those that don't know? And, how do you see that approach maybe different than just trying to do a big dose that is kind of very transpersonal, maybe provides an ego death experience? Because it seems like that's in the literature and the narrative that you need to have that type of experience. But, I'm also hearing, how do we not just blow that out and develop a relationship?
Right. So I think, again, I probably subscribe to a different philosophy. especially with this particular population. I think that there's a place for the higher dosing.
Yeah.
I would say predominantly, treatment resistant, low A scores, or someone who's just done a lot of healing work.
Yeah.
So I think for this population, that's not really the goal.
Yeah.
The goal, because what's really fascinating too is that what I'm finding in my work, clinical work, is that, what we're calling ego death, the parts take a time out when they feel safe with the situation. And then there's always the observer. So even with ego death, right, there's always some, call it consciousness or higher self or whatever resonates.
Yeah.
There's always something online. Otherwise, we would have no memory or recollection, right, of the experience. I call it the higher self. And I have found that actually is not dose dependent, but is really more with these folks. Again, this population, I want to be clear on that. High developmental trauma experiences, that that sense of safety and self-efficacy and feeling comfortable, that they experience the higher self or ego death at much lower doses that's in the literature, which is like typically, 1 milligram per kilogram is considered psychedelic with ketamine.
Yeah.
So that, again, that's just my biased, individual opinion and what I've witnessed in practice.
Yeah. For those that are listening that are maybe practicing ketamine therapy, what do you think is important for clinicians and therapists to know when they are working with ketamine with people with PTSD or struggling with trauma disorders?
I mean, I think seasoned clinicians, who've worked with this medicine probably are familiar with it, have a relationship with it. I think it's important that we honor it. Mm-hmm. Yes, it is man-made.
Actually, I think there was a paper published, and I learned this through our Vital program. Somebody mentioned it, that they found a fungus that actually produces, I don't know if it's ketamine specific or a ketamine-like compound. Really interesting. So it is found in natures to some degree.
Well, good. Maybe that'll help the stigma, because I feel like, racemic ketamine is, in the psychedelic community, kind of a redheaded stepchild.
Yeah.
And so, I think don't be afraid to incorporate, quote, ceremony. And if that doesn't resonate, because I think it makes a lot of clinicians maybe uncomfortable, that idea. Opening and closing can be very helpful tools. Making sure we're asking about intention before each session, so that, I call that the coordinates, because we want to give the unconscious mind the coordinates. Right. Yeah. And framing it into what we desire, not the negative, which is our tendency is, I don't want to, be depressed anymore. So we might reframe that, well, what is the desired, what would day to day look like? What is it that you would like how would you like to be in the world, and feel? And, making sure that we talk about intention, that has really changed. Those, I think those two things in my own KAP practice have been integral.
I think me too. I think like being able to do some of those like meditations, opening type of, we'll call it ceremony, but not really like ceremonial, but, trying to keep a little bit of that spiritual aspect out, but trying to include it. And I've always tried to find that balance there, right? Because we don't want to force our beliefs on, but we also want to facilitate this transformation and have the client really, again, I think it comes back to this agency piece. Like, how do we get them to trust their own process, trust their own bodies, trust their own psyche, and develop a relationship with that? And being intentional with this medicine, just not coming in and saying, I'm taking a drug and this drug's going to change me. It's like, this is a relationship.
Yes.
And how do we develop that and cultivate that?
Yeah, I think you're spot on. And I think we want to, make sure we're speaking to their protector parts. Mm-hmm. And that, the thing is with ego dissolution, we're essentially annihilating or bypassing. Again, my opinion, and that can be very meaningful and transformational. I think with these folks who have developmental trauma, we need to tread lightly, and not potentially rupture that trust between not just the client, but like the complexity of their psyche.
Yeah.
Right. Yeah.
I know client sensitivity. Just thinking, like, do you have any examples of like maybe something big that happened to a client? And obviously, keeping it confidential, but anything that really stood out to you in this work, doing this research, like a big experience that somebody had, they're like, wow, like, that really shifted me. Or
yes. Yeah, I mean, I think I can think of many examples, but I think just in terms of the context of like this conversation, I think about an experience where a client saw the perpetrator of ongoing childhood abuse, like in the experience, and was like, "Oh, there they are," and then the scene shifted into something else. And I think for that person, it was liberating to know that they could even not just think about this person that harmed them, but in this experience, actually like feel that they were there and present, and that it was not at all activating to their
That's amazing.
Yes,
it's amazing.
It was powerful.
And was there a narrative change there? Were they able to like engage in that experience and change a little bit of the narrative, or?
So the way that they described it, because it happened, during the KAP experience, and often there's a period of time where folks are nonverbal, right? That part of the brain, as we go titrate up on the dosing, it's harder to talk and form words. Yeah. But basically, they just shared that they saw the person, the perpetrator, and was just like, meh, there they are. And then right after that, the scene shifted into something entirely different. And so I think the narrative around that was like, okay, I can actually think about this person without feeling activated or angry or afraid. That again, the limbic, I think there's a shift, again, in the emotional memory associated with these experiences.
I've had some people mention it's almost like when they get that anxiety or they confront something in their unconscious during these sessions and they feel that anxiety a little bit, it actually helped them in real life because they were able to get through it in the session, and the ketamine helped to support that. And then bringing that awareness and practice into everyday life that, I've heard like, oh, like, I'm not feeling as anxious anymore because that came up in session. I realized I could do this. I found that to be really interesting, where again, it's like that little bit of resourcing. And if you've never had that, or that feels really challenging and you get to practice that, and then how do you bring that back into your life? I find that really interesting.
Yes. Yeah. And again, I think it does. It speaks to a lot of these folks have worked so hard. They've really shown up, trying to get and feel better. Yeah. So they have again, just an arsenal of skills. Like you're saying, they're resourced, but they're stuck. And I think some of it's physiological. I think some of it's perspective, which I think these medicines in general, like psychedelics, can really be helpful. Yeah.
So what excites you about this? Like, what's next? Like, do you have anything that you're looking forward to within this field?
Yeah. So I feel called to expand into more palliative care.
Oh, nice.
Because I think there's so much trauma for families and witnessing the suffering of loved ones as they transition. Yeah. So one of the talks was around that, and I actually connected with him. And so that might be something in the beginning of next year I would like to start doing and collecting data around. But the other thing that is in the works right now is a self-transcendent scale that we're using, pre and post induction. And it has some very interesting questions and
anything that you can remember off the top of your head?
Yeah. So what's intriguing about this is that it's, in this field, we think of transcendence as primarily spiritual. And there are some questions that speak to more developmental growth, which I think is integral with trauma too.
Yeah.
So as we start to have that sense of agency and we begin to ally and get to know our parts, the team better, that we start to not only show up for ourselves, but also have a desire to show up in community and connect.
Yeah.
And so it captures some of those shifts in perspective. Again, so under pointing back to the attachment theory focus, creating that safe container with the healing, right? Because our parts are frozen developmentally. And so as we begin to heal, whether it's with ketamine or other through other healing interventions, modalities, we start to mature in some different ways.
Yeah.
And so, yeah, that's I think what's interesting about it's a 15 question Likert type scale. So we're collecting that now pre and post KAP induction just to see what what if anything, right?
Yeah.
Is shifting and changing. There's an overall score too. So higher scores equate to more like having transcended where we started pre at baseline.
Yeah.
So that's in the works right now too.
That sounds exciting.
Yeah, it is. It is exciting. So I think what gets me excited is collaborating, having conversations like this, again, meeting like-minded people.
Yeah.
Because you're so right. I mean, this is an exciting field that's emerging, growing rapidly, but we still can feel pretty siloed.
Yeah. I mean, it's still a controversial and emerging field, right? And it's like we're out doing the work, but it's starting to become more acceptable, right? But it's also like, what are you doing? And it's like, yeah, we're on the front range like pioneers.
Yes. Yeah, we really are.
Challenging.
Yeah. So grateful to, people like you and your organization, helping educate, both lay people and clinicians.
Yeah. It's much needed. It
is.
So thank you. And thank you for your work as well.
Yeah, you're welcome. It's a privilege.
Yeah. Well, Dr. Montjoy, anything you want to close with? Where can people find you, or just any last thoughts?
Sure. Yeah, I think, in terms of contact, people can reach me at J Montjoy. My last name is Montjoy, one word, at ArizonaKAP.com. That's my email. You can also check out TRIPP's website, which is TRIPP, Arizona.org. And I think closing thoughts, I think, with this work, you had asked earlier just in terms of like any suggestions. And I think what I really try to convey to folks who I connect with, other clinicians doing the work, is just the importance that we continue our own healing work.
Mm-hmm. Yeah.
Right. And that we're maintaining our humility, right? As I say, I mean, I'm in the trenches doing my work too. I'm a wounded healer, and I'm not above or beyond anybody. So I think I would just encourage all of us to continue our own self-awareness, growing that, and doing our own healing work.
Super important. Yeah, I think that's a good closing reminder. So thank you for being here, and I'm excited to finish off the conference here at ICPR.
Yeah, thanks, Kyle. Yeah.
All right. Welcome back, everybody. I hope you enjoyed that episode with Dr. Jennifer Montjoy, all about ketamine and PTSD. I know I really enjoyed it. It's been just a fascinating topic that I've been just loving to dig into in the past year or so. If you have any questions, comments, anything like that, feel free to send us an email. It's info@psychedelicstoday.com. Again, that's info@psychedelicstoday.com. If you want to learn more about Jennifer's work, you can check Jennifer's practice out at resiliencetucson.com. And you can check out her practice, their team, and training and everything that they're doing over there at Resilience. So again, that's resiliencetucson.com. I think that's it. I hope, again, you're having a beautiful week whenever you're listening to this episode. So take care, everybody, and we will catch you on the next episode of Psychedelics Today.